Yeah, thank you, GIS, for invitation. So it's just a shift of gear a bit. I'm in cardiac imaging, so I hope that I will not keep you bored with this. So machine learning and AI is everywhere around us. So, and it's moving faster than what we think. But it's the problem with the AI in healthcare. It has been a bit slow, and you can see this is from data from US about a job opening in 2015. And healthcare was in the bottom of the list. But this is changing, because now we can see this is the number of paper just dealing with the cardiac CT, for example, related to the artificial intelligence, and it looks promising. So the AI can span all the steps of the management of patient, or the journey in patient with imaging, and I'm using CT as example, from the patient selection to follow-up and risk stratification. But we cannot cover all that. But there are two major areas that I'm going to cover, is the areas where human can do, but machine learning and AI can improve our efficiency, do it faster and more accurate. And there are areas where actually we cannot do it, we cannot see it, because for our eye, it is really very difficult to recognize. And some of these are, for example, CT-FFR or pericoronary fat assessment. So the ultimate goal of these areas is to improve our diagnostic accuracy as imaging, or to improve our clinical utilization of the cardiac imaging modalities without causing harm for the patient or doing multiple testing unnecessarily. So this is one of the examples where machine learning and AI can help us to improve the diagnostic accuracy. And as you know, for example, a cardiac CT has been linked to a huge amount of radiation at the beginning of the invention, that we are trying to reduce radiation by manipulating the machine, reducing the radiation exposure. But this has caused to have some noise, like this noisy picture, like this, where it is sometimes very difficult to see the coronaries very well, like this is the LAD, this is the RCA. But with the use of the AI and machine learning, we can convert this non-diagnostic or less diagnostic image to a very nicely diagnostic image, and this is called denoising images. The other application of image enhancement is a motion, and you know, it's cardiac CT is always having problem with continuous cardiac motion. So cardiac motion and motion artifacts in cardiac CT is very common, and without having a very efficient algorithm for correcting this motion artifact, we will have non-diagnostic images like this in the mid-RCA. But with the machine learning AI, we can correct this and we can convert to diagnostic imaging. There are areas we can do, but we are slow. For example, this is calcium score, so we have to span the axial images, and whenever we see calcium there, we make a circle around it, and then we have to label it. And after labeling, the machine will calculate it for us. But what if we ask the machine to do it for us? So the machine will just scroll the images completely, label all these coronaries for the RCA, LAD, and also label them, and will give us the answer in maybe less than 1 minute. So instead of having like 10 minutes or 5 minutes calculating all this calcium, we can do it in 1 minute. Again, as with all things mentioned, there are some pitfalls, and sometimes machine learning or AI can't recognize artifact or calcium somewhere else, but this is with improvement and more training, we would have better algorithm to calculate calcium score. With regard to the coronary assessment, I think it is a very complex a process. We can see, for example, we can start from labeling the coronary, for example, segmenting the right coronary artery, left coronary artery, then we label it. Then we have to have an assessment of the coronary stenosis, severity, what is the calcification, how much atherosclerosis there, and then we can also have some physiological assessment, or we can have something which is outside the coronary, which is related to the coronary inflammation. As you can see here, this process is complex and takes time. And for a busy lab for like our hospital, to do this is gonna be really killing our like time, and also the waiting time will be longer. But if we ask the machine learning to help us, or the AI to help us with this, for example, this is an axial image, and we don't see the images like this. Now with the machine learning, we see it like this. It's completely labeled. You can see this is, for example, LED, this is the diagonal, those are the LCX, and each labeled by different color. And this is now available. The good thing is available now. And if we just go one step further now, I can click on this, and the machine will tell me, oh, this is now, look at this is LED. So the machine knows that this is LED. Just click on it and will label it for you and go next and next. And then we will have images like this where we can have a comprehensive assessment. As I mentioned to you, it's a comprehensive assessment. Most of the lab now, they are using normal, abnormal, is it severe obstructive, mild non-obstructive. That's it, because if you add more and more complexity of reporting, you need more time. But the CT can provide us with a lot of data about the atherosclerosis. How bad is the atherosclerosis? How long is the atherosclerosis? Where is the location? What is the calcification? What is the density of calcification? Is there any proximal or distal? Is it multivessel or single vessel? And this list of 15 parameters is getting longer and longer. So how can we report all this in a busy lab? So I think the machine learning and AI can help us a lot. And for example, this is one of the more validation or testing. So this was from the Confirm registry, where they took images from CT scan that has been already reported by class 3 or level 3 cardiac imaging experts, and then they ran it to the artificial intelligence algorithm, and they compared the diagnostic accuracy of artificial intelligence to the level 3 expert reader. And what they found, there is an excellent correlation between the reading by the experts level 3 and also this model. And this is probably one of the first models, and this is getting even better and better and improving. And combining even this with physiology, for example, here, in the same setting, we are not adding any extra test. We are doing just a CT, so we can do physiological and anatomical assessment. And as you can see here, this one, we can see this image, which is anatomical. Is this causing, for example, ischemia or not causing ischemia? We are not adding any contrast. We are not adding any more radiation. We can just run automated coronary segmentation, and then CT FFR will give us all the physiology and will improve our diagnostic accuracy for this lesion, which is important and causing ischemia. So and also combining this with more robust atherosclerosis, comprehensive atherosclerosis assessment. Easily, for example, the AI can go through one vessel like LED like this, and going through it, it will tell us how much atherosclerosis is there, what is the consistency of atheroma, high-risk features, calcification, density of calcification, and will give us very nice information about how much atherosclerosis is there. Of course, with more adding tests, there is more adding cost, and this is one of the studies by UK analysis, where there is a little bit of adding cost to this, for example, compared to other imaging modality. For example, should I have like an additional SPECT or PET imaging after a CT, or I just ran a CT FFR? So yeah, there is some added cost more than SPECT and stress CMR, but I can tell you, in our hospital, we mostly use a PET, which is more expensive. So if you use our data in our hospital, I think it will be either comparable or less expensive. We can also use this to improve our, for example, risk assessment of the patient. This has been mentioned. This is fat attenuation index. And this, we cannot do it by our eyes. We cannot recognize it. And asking the AI to recognize this fat around the coronaries and to tell us the characteristic of this fat and how much inflammation there. If you compare it to the standard CTA, for example, it would just improve our risk assessment for the patient, and the outcome will be worse if there is more inflammation there. There is more and more using artificial intelligence in structural heart disease. I know this is not structural meeting, but we discussed this a lot in the structural meeting, even the GIS valve. And for example, you know, in the structural heart disease, there are many parameters that we have to incorporate in the report. For example, TAVI, we need to do the LVOT, the annulus, the sinotubular junction, the height of the coronaries. And this takes time. It is time consuming to do all these things. So now the AI can just, and this is existing now, we can just run the CT, the algorithm will tell us, is this the points that you want to recognize for the attachment of the valve leaflets? And we confirm. Once we confirm, it goes to the next step, the location of the coronaries. We just confirm, not doing anything. The machine will just do it all for us, and once finished, it will give us all the measurements from the LVOT to the whole assessment of the root and the coronaries. So what is the challenge of the CT? Challenge of CT is because the access is limited. Not all the hospitals have high caliber CT. Training is very long, laborious post-processing and long waiting time, like in our hospital, 6 months waiting for CT. And it has been shown that if you ask less experienced people to report a CT, they would tend to have less quality reporting. For example, this study showed that if you use less experienced people, they tend to overestimate the severity of the coronary stenosis compared to core lab. So can AI help us in that? So I think this is the final slide that I want to spend more time with it. So as imaging guy, I would use AI. I would like to use the AI in two different settings. A setting where I am available there, I'm expert, I'm available reader, but I have also less expert reader, my fellows and residents. So they will help me to do more cases, and then I can validate findings and report. But also AI-powered analysis can also do more and more cases for me, and then I validate and I make reporting. So this way I can have two sources of, let's say, good reporting, let's say, that I can validate and report finally. What is more important, actually, if you don't have an expert reader in that hospital, where even the patient selection can be difficult, which patient should go for CT. Image acquisition can be also very difficult. So maybe we can ask AI to help us to optimize the protocol for us. What is the KV? What is the, for example, what's the radiation that we have to expose the patient to? And then the acquisition, and then the reconstruction and calculation and segmentation, all done by an algorithm in a remote hospital. And also that remote hospital, they can make it a priority for high-risk features like severe stenosis. They send us this to more experienced reader, validate, and also can give reporting. By this, actually, we can reduce the waiting time, make the remote area not isolated from other areas where expert readers are there, and we can have very high quality images, more comprehensive image assessment without any compromise on patient care. Thank you.